We also have the offline participation of other excellent colleges who will share their contribution with us. Keiko from Japan, Shona from Canada, Tazin from Pakistan, Beatriz from Colombia, Paula from Colombia, Beck from Singapore, and Lorena from Mexico. The videos of these contributions, as well as the recording of this webinar, will be available at the CED website from next Monday.
And now we move to the final part of the agenda, which is the faculty panel and questions and answers from the participants. And I would like to ask the first question to Adriana. Adriana, which is the greatest challenge for a woman in a professional clinical engineering role?
Thank you. Thank you, Kaliroy. I think the most, the greatest challenge is to keep a balance between your personal life and family and the professional work. That is really the most important, because you don't want to lose the perspective of taking care of your family, but also working in health, which is all the time. that doesn't stop. There is no holidays in health. Things happen all the time. So that, for me, it's the greatest challenge. And to understand exactly the needs from the healthcare workers, the needs from doctors, the needs from patients. Thank you.
Thank you. And if you would recommendation to a girl who is watching us today and would be interested in entering the clinical engineering world, what would that be?
To go to a hospital. It doesn't matter what they want to study, if they want to design or any kind of equipment. It would be really to keep on, to visit hospitals, to talk with doctors, to talk with nurses. Nurses are the best users of technology. So go and talk with them and meet with them and see what are the challenges, talk with patients, learn exactly from the floor, what is happening, where are the greatest needs, what can you do to solve the problems? And that will really help you in the work that you do later.
Thank you so much, Adriana.
Could I ask? Sorry,
Fabiola.
Okay, the next question is for Dincy. Very little has changed in the past 20 years regarding how donations are made. Why are you hopeful that anything will change going forward?
Well, now I am involved, that's why. Yes, definitely very little has changed in the last 20 years, but now we have systematically started collecting information about donations. You know, when I did my thesis, no one else had attacked that problem or tried to address that problem at an academic level. So in the past, we used to have mostly anecdotal information. If you sit in a room with 10 biomedical engineers or clinical engineers, lots of stories about what they see at their various sites. But now there has been better compilation of data and evidence as to exactly what's happening. And we're seeing trends around the world. So that's the first thing, is collecting the evidence on what's happening, and then also working together. So the WHO plays, for example, a very key role in this work, where we have a centralized repository of information, and that's shared around the world, such that if a donor comes from Bulgaria, for example, and wants to donate equipment in Paraguay, I'll just give an example, they should go through very similar processes as someone coming from Germany and donating in Rwanda, whatever the country is. So that's the thing, having this commonality in a global sense and approaching it together, I think is accelerating the changes and making sure that now things will be different compared to the last 20 years. Thank you.
Thank you, Dincy. And I would like to ask Fiza, how does it feel to work with such a tremendous multidisciplinary team that you lead?
It's an amazing experience. So the other co-founder is my brother, And as Adriana mentioned in the beginning, it's very important to have a very strong support system for you to work, not just in developing countries, but even developed countries, so that you're always motivated. There are a lot of challenges that come in when you're coming on ground and working in places like Pakistan, and having a very strong support system. And in my case, it's my other co-founder and my brother. So I've been very lucky in that sense. And then having two other people on the team who have a lot of experience in terms of the technical and the business aspect is also really important. So when you're working in a team, having the right skill set, having people who are able to actually brainstorm with you, sit with you, and you all have kind of the similar experience, so that you are passionate about what you're working on. I think having a mission-driven startup is very important, and the fact that we're all very grounded to it is what helps us going. Hello.
We heard you, Fiza. Thank you very much. Would you like to add something?
Thank you.
Thank you. Okay.
No, that's all I was going to say. I think my internet.
Great, thank you. I would like to make a question to Gabby. Gabriela, how clinical engineers can contribute to guarantee the quality of medical products?
Hello, yes. Well, I think that the knowledge of the, first of the knowledge of the, also the knowledge about regulations, regulatory frameworks, and also the, the different, regulatory frameworks, and also the specifications that they, that a device in terms of material, in terms of size, if we're speaking about specific devices, can give a bigger sense of what's a quality and safe product to the to give to use in a hospital or in a specific country. I think that it's important to fill that gap of reality, and it's about the quality and safety, of course, of a device, but also it's about the device be appropriate for that context. And for example, in low resource settings, we think, okay, this is good because it's small, and maybe it was used. It's normally used in an ambulance, for example, a nebulizer. But then maybe this nebulizer, it will be used in a hospital in low resource settings. Yes, it's small, but this is not what it's needed. So the nebulizer can have all the quality and the regulatory background and acceptances from many governments, but it's not exactly what it's needed in the field or in the at the hospital level. So I think that it's this bridging this gap about the need, and also the knowledge of the device itself, and also the context and the regulatory environment of those devices.
Thank you, Gabby.
Thank you, Gabby. I would like to ask Eva, which area of clinical engineering is most appropriate for development women's activity and creativity?
I think, as I have told in my presentation, what is the unique possibilities of women. I think that it is first of all this empathy and thinking how to help in any situations, and also creativity in this helping. So I think a much important area of working is the field as close to the patient as possible. So working as a partner of medical team, and keep the direct contact with patient and application of medical equipment to this. I think that this these unique abilities of women are very important in this kind of activity in clinical engineering field. So I think that work in a hospital and very close collaboration with medical team is the best play for activity of women. But of course, any other fields are also very fruitful because women always have such point of view which is in developing of thinking how to help and how to do it much effective as possible. Thank you.
Thank you, Eva. Rosanna, I would like to ask you a question. What are the opportunities to contribute to improve the ecosystem of women in clinical engineering?
The opportunities are diverse. All of them are challenging, but very exciting as well. I like to thank the coaching description of my participation brought in by my amazing colleague, Fabiola. But my point is to set that health technology policy is not an academic issue or a political issue, is an essential issue if we want to achieve operational, strategic, and most of all, equitable objectives in healthcare among the world. Going back to your question, Kali, women should be able to be part of the roundtables, as Eva well stated before. We should be part of the roundtables on which the regulation and policies are discussed. Also, in the areas of decision-making processes, it could be the academia, it should be for sure the government, but also all other stakeholders engaged with the ecosystem, and I may say enterprise, non-profit, the church, the army. And for that to happen, women in clinical engineering should be very good in their field. If you ask me, I not just talk about clinical engineering, I am doing it with a lot of conscience that my margin of mistake is very narrow in comparison to any respectful, kind male colleague. This is not the fact in the Americas. In the Americas and other countries, you may know, they expect no male should demonstrate their capacity. They used to listen, they used to call him, them. For women, it's not the case. I am, through the years, just to provide my case as an example, but it's not a unique one. One of the fewest, or just the one, or the fewest women in the roundtable, in the discussion, in the conference. So I need to be kind, not be mad, be polite, but also work more to demonstrate that I have something to say in the profession. Yes, it's coaching sometimes, yes, but it's more very hard technical, very strategic, and much more. It's a result of a sustained training, international and local process I do daily, no matter what, before and over the pandemic. Thank you.
Thank you, Rosanna. We have some questions from audience. The first one is an open question. How is the perception of the gap between different states in the international community when it comes to the time of access to medical devices and supplies regarding COVID-19 emergency? Would like to answer?
Yes, Fabiola. We always observe around the amazing results from international colleagues, international countries. The path for the Americans and low-income settings was and keep being to be able to be trained, aware about the news, best lessons, best practices, and exchange it and also discuss it with the correct environment and the most selected stakeholders to make the change happen. So the way I will use two branches, okay? The accessibility to medical devices and the access to healthcare services, both of them urgent issues, won't change if we just think about the government change or the ministry realize there are a number of facts, and now the emergency of the pandemic. We need to think from the bottom to the top, to move the top enough for them to change now. We are now dying. We are now out of the hospitals, and kindly opposite, I am kindly opposite to another colleague, not today, but some days ago, who said, Peruvians prefer to stay in home. No, Peruvians don't prefer to stay in home. They have to stay in home because there are not enough hospitals, neither private clinics, to support the number of persons who need to go to the hospital or to the clinic. And they don't have, in average, the money enough, okay, to buy medicine and oxygen and blah, 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 etc. They do not prefer. They have no chance. So again, to make the change happen, we need to go from the bottom to the top, and it means be able to be part of the correct organization with the selected correct stakeholders and make them more awareness, empower them, not just with the emotion. I could be emotional, I'm passionate for my profession, you could see it clearly, but also with knowledge, methods, approaches, best lessons, practices, and technical documents. With that, things may happen. I am a believer, things should happen. Thank you.
Thank you. Anyone would like to answer this question also? Okay. We have a couple of questions that were in the chat and partially answered. One from Cesar Akum. Are there minimum regulatory requirements set and can be shared for emergency situations in COVID-19 context? This question was answered at the chat if you like to check it out. And we have another question from Mei Bang. Hola May. What has been the greatest challenge as a woman in biomedical engineering?
Fabi, can I comment?
Yeah.
Fabi, I just want to tell the participants that the first time I went to get a job, I was denied the job because I was a woman. And I think we just have to persevere and continue our way and find alternative ways and find the way forward and never take no for an answer. And especially if it is just because of being a woman. So I think we're all to help, and you can do it. Thank you.
Wonderful answer, Adriana.
Could I address that? So yes. Perhaps I've been lucky, but also I had the passion. I knew what I wanted to do. So no was not actually an option for me. So I wasn't looking to be accepted as such. I knew from a very young age that I wanted to go into biomedical engineering. I liked machines. I wanted to help people get better. The two fit perfectly. Biomedical engineering was the only umbrella under which I could work. So for me, that understanding of exactly what I wanted to do was my driver. And it led me to seek out opportunities where there were no opportunities. When the rest of my classmates were doing one thing, I was headed in a different direction because I knew exactly what I wanted to do. So that passion, I think, definitely helped. I would also echo what Adriana said at the very beginning, having parents who supported me in my quest for science and encouraged me in following my passion. So having that support also definitely helped. Thank you.
Thank you, Dincy. Anyone?
Hi, Fabiola. I just want to complement that maybe passion is, well, for example, sometimes we speak about passion and then we say, okay, well, but well, maybe you or a young woman, they don't know, well, she doesn't know what to do later. But I think that also like studying and knowing and knowledge about the science and those things can create the passion. So maybe it's not at the beginning, but knowing and working on that can bring as well like the passion for this job. It's not just like appearing or all.
Okay.
Just compliment.
Thank you, Gabby. Okay.
Fabi?
Yep.
Can I just add quickly?
Yep.
I just want to say that was my first job, but even today, my job is not easy. So our jobs are not easy. Every day we have challenges. Every day we have to go through them. And I think together we can all work together. And as Gabby says, with the passion and the goals that we have is to keep your goal in mind. It doesn't matter how many stones you find in the way, you can go around them and keep on going. So that will be my message. Thank you.
Wonderful message, Adri. Okay, well, today we have heard the voices of women whose proactivity, leadership, enthusiasm, and passion for clinical engineering not only inspire us, but also push us to do our best. From our trenches, we are promoting important changes that affect the well-being of the patient and the population in general. Let's continue with the effort, with the certainty that we are seen and supported both by the network of female clinical engineers and by our male colleges. It has been an honor to have taken part in this activity. We are waiting for you tomorrow for the second webinar, Women Addressing Today's Health Technology Challenges, where another group of extraordinary women will present important topics related to female participation in clinical engineering. As for me, I thank our panelists for their participation, Calroy for her support, and you for your presence. See you tomorrow. Kelly.
Thank you, Fabiola, and thank you all for your participation today, and see you all tomorrow in this interesting webinar with SHE colleagues from all over the world. Thank you.
Thank you. Bye.
Thank you very much. Thank
Bye.
you. Bye-bye.